And we are live. Welcome, everyone, to the Melanin Initiative podcast. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner and one of your co hosts here at the Melanin Initiative podcast. Here, we believe that in healthcare, there is often too much information and not enough time. Here at the Melanin Initiative, or TMI, we avoid TMI by breaking things down into language you can understand. We create a safe space for you to ask your questions and share a nursing perspective without taking up too much of your time. All month long, we've been recognizing Breast Cancer Awareness Month. Each of our guests has been sharing very personal stories to allow us a better glimpse of what the experience is like, both personally and through our family members. We're so grateful for each of them who came on and spent some time with us. And we have to thank you all. We have had some really wonderful support. In fact, my mother here, Reverend Leona Madison, her episode when we talked about her diagnosis was the fastest one to reach 100 views since premiering. And her second one is actually doing better than that one. So thank you so much. By the time you hear or see this, we've already aired our first episode with Lori Lee, who was kind enough to come on and share her testimony as a daughter of a woman diagnosed with stage 2 breast cancer, only to go into remission, meaning that there was no evidence of cancer, later to then be diagnosed with metastatic breast cancer, which she did die from. You also showed a lot of support for her and her business, Trisha's Precious Gems. And we were so elated when we heard that her younger sister, Paris, wants to come and talk to us too. We are at the end of the month, and I'm not quite sure if we'll be able to air her episode in this month in particular, but we will have her on. And so just make sure you like, follow, and subscribe so you can be notified when that comes out. You all have reached out and inquired about her sister. You've shown a lot of compassion and concern about her to make sure that she does go back and get her follow-ups. Because we emphasize so much in that episode and beyond about the importance of early detection. And so you all followed along in that story. You understand the importance. And in that story, Lori did share that her sister hasn't done it yet. And all of you sent in so much concern. And so we want to make sure that message gets to Paris. And so if you have any questions for her before she comes on, please send them to our email, or you can even send them to us via Instagram or Facebook. All of our social media links are in the description box. We're doing this whole special on all October long because so often people think they're the only ones going through something. And that leads us to suffering in silence. We know and hope through this show, you'll see that you're not alone. And there are a number of resources there to help you. We hope you'll be motivated to do what you can when it comes to your health, particularly early prevention, establishing a relationship with your primary care provider who can identify your risk and talk to you about the available resources. Most importantly, we hope you'll understand the importance of early detection, which we cannot emphasize enough. Every time I talk to my patients and their family, I say, I'm not just taking this time to teach you. I'm doing it in hopes that you'll gain something from it, but that you'll also go out and share this information. And that's what we want to do through this podcast. So we hope that you share this information as well and not just keep it to yourself. The data shows that when it comes to Black and Brown communities, we wait too late to be diagnosed. And once we are diagnosed, the disease is often so advanced that the options are limited. And then our experience with our healthcare providers and in the healthcare system tends to be a lot more negative than it has to be. And the anxiety, the depression, the fear is at a severe level that it's really hard for people to even reach us and help us in the way that would be best for our benefit. Knowledge is power, and so is having a support system, which we've talked about over and over and over. It's been a very common theme this month, and so is understanding the importance of advocacy. We've addressed these themes all month long. We've released new episodes every Tuesday. That is when we release new episodes, every TMI Tuesdays at 10 a.m. But of course, you can go back and watch our old episodes and look forward to season 2, which officially kicks off in November. The ladies, Geraldine and Alicia, will be back. We've already started filming, and we can't wait to share with you all the content that we've created. You can continue to send in your questions, your ideas for show topics, and we will address them. It's not in this season, certainly in the future. So as I've mentioned previously, since I was really familiar with my mother's story, I thought we would do it more justice by breaking down each phase of her journey so that we can really get a better understanding of what that's like instead of rushing through her whole story in 20 to 30 minutes. So in her first episode, we talked about her diagnosis. You can go back. At that time, she was diagnosed with stage 1, and then we came back and talked about her treatment. She was recommended to have surgery, specifically a lumpectomy. Chemo, she did 4 sessions, about 3 or 4 weeks apart, and then radiation, which finished out that 2012, the rest of 2012.
Yeah.
She got diagnosed about the end of April. Surgery was in May. Spent the whole summer doing chemo, and then September to December radiation. And so we talked about that in the last episode. So today we're going to talk about life after treatment, side effects, what her health has been like since that time, what the follow-up looks like, her mental health, her faith at that time. We'll really get into her faith in the next episode, so make sure you stay tuned for that, okay? So often particularly in Black and Brown communities, faith and medicine can be on opposite ends, kind of competing. And so we really want to be able to dedicate a whole show to kind of discussing those concerns, okay? So welcome back, Mommy.
Thank you for having me.
So how's it been being famous?
Oh, I'm so excited. I'm telling you, it's just been a great experience to be a part of social media and all my organizations. I'm supporting the podcast, and thank you so much, for making Mommy famous.
Okay, so we're just going to jump right into it because we have a lot to go over. So we're going to start talking about those side effects. So first thing, we're going to go back to the surgery. So your surgery, you didn't have any complications, right?
No complications.
So often we spend so much emphasis or even energy thinking about surgery, labor, or the wedding, when really all the work is the post-op, the parenting, and the marriage, right? Mm-hmm. And so fortunately for you, it was an uneventful surgery. You had a lumpectomy. Yeah. And so usually we do quite a bit of teaching on this show. For the breast cancer special, it was more about sharing people's stories, giving them a platform and the space to do so. But we're going to kind of merge our two kind of methods of giving information together today. So we're going to bring back our slideshow. If you haven't seen our previous episodes, sometimes we add pictures to help get the point across, make it easier for you to understand. So a lot of people are familiar with the mastectomy, which you can see there. And that is the removal of the breast tissue. So depending on how large the tumor is and where it's located, there may be more or less of the tissue removed. You can see the entire nipple has been removed, and that small line going across the chest is the incision, a healed incision specifically. And so what can happen following that surgery is you can go back and meet with a plastic surgeon who can do what we call reconstruction. Not everyone chooses that, and not everyone has to choose that. That is just an option that is given to you, and it can be, insurance can help to pay for that. So my mother, she had a lumpectomy. So with the staging, I'm going to come back and do our one topic at a time and talk about what staging means and what the different ones are. But the lower the number, the smaller the tumor, and the less other organs are involved. Once we start getting to stage 4 and metastatic cancers, that means other organs are getting involved. And that can also include the bloodstream. Once cancer gets into the bloodstream, it's a lot harder to treat, and it can take a lot longer to treat. Just think, if you have a spill right in your lap, you can just clean that up with a paper towel. Well, if your whole fridge leaks, that's your whole entire floor. Now it takes a lot more paper towel or mopping or resources to clean that up. That's just like having something into your bloodstream. So unlike the mastectomy, where you have to remove the whole tissue, and that can be because you've been diagnosed, or maybe you have had some genetic screening, genetic testing, and it shows that your chances of getting breast cancer are really high, and you might choose to have it removed even though you don't technically have breast cancer, but you have the gene. So that's a popular option. You can have one or both breasts removed, whether you are male or female, meaning you have male or female body parts. Now, the lumpectomy, all they're removing is that particular tumor. And it might be a little bit harder to see on that picture, but there is a small incision there. And that's because only that tissue was removed. And so that's what we're trying to do. If you are, of course, we don't want anyone to be diagnosed with cancer, but if that's going to be the case, and specifically if that's going to be breast cancer, we want as little tissue removed as possible. We want as least invasive of a procedure as possible. So that's the difference there. Anything you want to add about surgery or anything after surgery?
Well, I just want to say that when I went to the first provider, my the pathology report actually showed that it was 1.7. But by the time I got to the second provider, which was the military, because I had dense breasts, they detected that it was actually 1.8.
Okay. Yeah, and so they will. Sorry, that's our mascot in the back. And so what they will do is they will measure the size of the tumor through all the imaging. They're able to do that. Of course, even with the best imaging and with the most highly skilled clinicians, once we open you up, that's where we can really see everything that's going on. And so some tumors grow really slowly and some are aggressive, meaning they grow really fast. So yeah, I'm glad you brought up the size because that is something you will hear about from your team is the size of the tumor. And then they'll confirm that size when they actually open you up and go inside.
Exactly. And it's exactly important, if I could say, to know that whether or not you have dense breasts, because I had never heard that term until I actually went for my first examination. And the nurse actually at that time, when the oncologist came in, she said she has dense breasts. And so he was like, very interesting.
Yeah, actually, I'm glad you brought that up. So you can find a lot of times you'll be told that either when you go to your gynecologist or whoever's doing your breast exam, they might tell you that when they perform the breast exam, that's when they're using their hands, their fingers to feel around the breast itself, up in this area here, and then into the armpit. These are popular sites for cancer to appear. And so at that time, we can tell whether you have dense breasts. That might be the first time you hear it. Certainly when you go have a mammogram, you might hear it. And then they might order a specific type of mammogram for your breast tissue. And so that's good information to have. That's a common thing, especially in the Black community, is dense breasts and also fibrocystic breasts. And that just means it can just be a little bit harder to detect changes, or the tumor, you might feel things and it's just dense tissue. It's not necessarily a tumor. And so the more you're familiar with your body, meaning the more often you perform that exam yourself, different times of the month, before and after your cycle, you'll know those changes. They'll be very familiar to you. And that's information you should share with your providers because you're going to know your body. You see it multiple times a day. We might see you once a year. Okay. So good. That was good. And then some other things you could have from surgery. Pain could be a problem. You'll go home with a prescription, nausea, and particularly if you are taking pain medication, the side effect of all pain medications is constipation. So you're encouraged to move as much as you can because movement sends blood to your GI system, which helps things move. Stay hydrated. Again, it helps things move. And if you need to, you can take a stool softener that can soften the stool or increase the amount of water that is sent in that area to help things move, as well as eating fiber. Fiber is usually found in raw fruits and vegetables, particularly if you use to keep the skin on, and as well as like beans, grains, oatmeals. All those kind of things are high in fiber, and they keep us regular. Regular meaning that we go at least 3 times a week. I know some people are freaking out. They're saying, I have to go every day. But the textbook definition of constipation is actually less than 3 times a week. Is it great if you go more? Yes, that's wonderful. It's fine as long as you don't have any problems. But if you go less, and as long as you meet that 3 days a week, that's good. More than that, I mean, I've had, obviously in the hospital setting, we're seeing the worst of the worst. Certainly there have been patients who have come in, they haven't had a bowel movement in 2 weeks. That's way too long. Just taking the time to share that information. Okay. Now, if you've seen specialists for years and it's normal for you, that's different. If this is the first time you're experiencing that, that should be a red flag and a sign that you should make an appointment with your provider. Not unless you're having severe pain or unbearable pain, pain that's not well controlled on over-the-counter medication, then you can go to the emergency department. But if you think you can get by and just go see your provider, take that into consideration. Okay, so chemo, that was your next phase, and you had a Mediport, and you talked to us about getting your Mediport before.
Yes.
Did you have any complications from your Mediport?
No, I didn't have any complications. I just had to learn how to sleep on my back pretty much because, I had the lumpectomy on the right and the port was on my left. And so, but what I would do was use a little pillow to kind of like prep myself up. And once the chemo was over, I chose to have it taken out, even though it was recommended that I could keep it in just in case. And I was like, there's no just in case here, And so but I didn't have any problem. It was easier for me.
Okay, good. So let's take a look. So this is the Mediport. You said something. I was gonna follow up on that. Oh, the sleeping positions. So, because she had a surgery, there were certain restrictions for that. But some people will have a Mediport. She got it for chemo. Chemo is very toxic to our blood vessels, so we can't use a catheter in the arm in that case. So it has to go into a very large blood vessel that gets a lot of blood flow. And so it's going to be placed somewhere in the center of the body. And that's the Mediport is a very popular option for people on chemo. It's placed under the skin. They'll make a small incision to the skin and place the that whole device will go under the skin. The white tubing will get fed through the blood vessels, and the tip of it will be at the top of the heart. And so we call this a central venous access device because it's centrally in the body. So people can have them when they're going to get frequent infusions, and that can be chemo, and you can see it a lot in sickle cell. So maybe you've heard that she's not a big fan of needles, and so for sickle cell in particular, they get a lot of blood transfusions, and they don't want to get stuck a whole bunch of times either. And this helps to make it much easier, especially if you get treatments like chemo, dialysis, or even if you've used IV drugs. It makes your blood vessels really, really, really frail and tiny, and it makes it much, much harder to get blood from you, and this makes it much easier. So that's the device outside of the body, and they can be different sizes, shapes, but this is just a general idea. And so this is what I was talking about, how that white tubing will get thread into a very big vessel, and the very tip of it will be at the top of the heart. And so there's a lot going on here. So the main thing is two things. It's a foreign object in the body. So we want to prevent blood clotting around it, and we want to prevent infections. Those are like the main teaching points that we go through with patients, because there is now an entry point into the body that's not normally there. And so this is what it looks like once it's placed. You can kind of see the faint scar there. So after they place a little incision, they'll use some a local anesthetic to place it, and then some skin glue. It's a very thin incision. It slips right under. And this is how it should look. It should look very healthy. Depending on how much fat you have underneath your skin, it might kind of protrude like that one does, or you might have to tell someone it's there and they can feel for it. And these are just two different examples. And this is a healthy looking site. There's no redness, no swelling, no drainage. Anything you wanted to say looking at those?
It looks familiar.
And I mean, the person who has it is probably very conscious about it. But for other people walking around seeing you on a daily basis, they're not thinking about it.
Right.
And you could see how this easily fits under, regular clothing. And you can take a bath, you can shower. There's not as many restrictions as when you have a catheter that hangs outside the arm. Mm-hmm. And so that's why it's really great for long-term use. Now here I picked his picture, one, because we want to make sure that we when we're talking about breast cancer, we're not just talking about people with female body parts. We're also talking about men, because men can also get breast cancer. But I included his picture in particular because you see it is a little bit red. And so I don't know if he's having just a reaction to like an adhesive, or maybe he just came from treatment and maybe they had to poke out quite a bit, or maybe he's on a blood thinner. I don't know. But I just want to give you a comparison between the previous slide, where there was no redness, it was skin tone. And now we have a little bit of redness. Now, if he stays red like that all the time, it's normal. It's normal for him. But if that's the first occurrence and nothing's happened, or he did just have a treatment and they told him, if it turns red, give us a call. So this would be a time where he would want to make that call. Did you have any problems with your Metaport?
No, I don't have any problem. It was like 2 weeks that, I was trying to get used to the fact that it was in there. It felt like maybe a little hard, But then after that, once I start showering and stuff like that, and exercising that arm, then I didn't have a problem with it.
Okay. And then, yeah, okay, that's good. Okay, and so now you have that. Oh, so I was going to say. So I showed the picture before, how the tip is in the top of the heart, and our two concerns are infection and blood clotting. So if you're getting infusions pretty regularly, like she was going every 3 to 4 weeks, that's pretty regular. When she goes, it's going to get flushed, which means some fluid's going to go through there, so that if there's any blood at the tip, it's going to get flushed away. But if your infusions are very infrequent, maybe they're every 6 months, or they're just whenever you need one, like with sickle cell crisis, they might have you come back every so often, and they might flush it with heparin, which is a liquid blood thinner, and that will just help prevent blood clotting around the site. So how do we get into that catheter? Here's a picture of that. So when you go to your infusion center or you're a patient in the hospital, the nurse will clean that site and then insert a needle. I've done it many times. Some people maybe kind of, I don't know, might be a little apprehensive, but for the most part, it's not nearly as painful as when we have to stick you in the arm. What's your take on that?
Exactly.
Okay.
Exactly.
Yeah. Most people are super happy to get a central line. And while I've talked about a lot of the benefits, I've also talked about the risk. And we always are trying to avoid those risks. And so if you really don't need a central line, we want to avoid it, because that risk, if you have one of these catheters, your risk for infection is greater than the general public. And so we want to avoid needing blood transfusions or needing antibiotics, having to be hospitalized. But it's a great option for the people who are the best candidate. And so that will get inserted into the skin, and they'll put a clear film over it, Tegaderm, a dressing, to keep it in place and to protect it. Then the nurse will attach here we have a syringe at the end. Looks like she's flushing it to make sure that it's in the right place and that it's working. So that's normal saline. Flush it, draw back, make sure you get blood return. That means that blood is coming out, as you can see in the tubing there, and that's a good sign. That will then get attached to another piece of tubing, and that will be the chemo itself, which is that liquid medication. Sometimes people can taste the saline. So a lot of times when I flush a catheter, no matter where it's at, someone might say, "Oh, I can taste that."
I didn't taste it.
Oh, okay. And then this is a picture of a chemo room.
Yes.
So you see everyone's wearing a mask. And so as long as you're on chemo, you're going to be highly advised to wear a mask, especially if you're going to be out and about amongst the public. And again, we have a patient there sitting in the chair, and we have a chemo nurse, okay? Lots of nurses might administer chemo, either the liquid or the pill, but there are specific chemo-trained nurses, and they know exactly what they're doing, okay? And so the room, like oftentimes you'll be in the room with other patients, and it might be very open, like the picture on the bottom, or you might have some curtains in between. What was your room like?
I had a private room.
Oh, okay.
Just myself.
Okay. Mm-hmm. And was it cold?
It was cold, but they brought me some warm blankets, and I wore a sweatsuit, so I was warm anyway, and a hat.
Wonderful. Oh, so now, so there are some side effects of chemo. Did you have any nausea?
No, I didn't have any nausea. They sent me home with narcotics, but I didn't have to use any of it.
Okay.
Yeah.
And that's another word for pain medication or opioids. They're stronger than your Tylenol. It does require a prescription, and that's because the side effects and the risk of respiratory depression are much greater when you take a narcotic. And so you'll be given a prescription electronically, and it'll have a fixed number of pills that you can receive within a certain time frame. And again, that'll be accompanied by stool softener. So the main thing we talked about before, your nails. So
Yes,
here's a picture of
nails
that.
and toenails, yes, turned black.
Okay, you want to talk about that? And I'll take our slide away.
Well, that was very interesting because I always like to keep my nails and toenails, painted up and stuff like that, which I still did, and it didn't last too long, but it was very noticeable. So I would put, red polish because the radiologist oncologist, she said, you could put um, nail polish on, but you can't go and have your nails done.
Mm.
So all that, anything, your hair, your nails, you shouldn't, you should just cancel that for the next 6 months. And so I did that. And so by the time I was finished, she said, now you can go and, get your nails and stuff done.
But you really don't get your toes done.
No, I don't get my toes done because mainly I don't like people touching my feet. And but during that time I just did it myself.
And did you take was it a long time before you went back to the nail salon? Even though they said 6 months, did you wait longer than that?
I waited longer than that, probably like a year and a half. Yeah, because I was conscious of chemicals on my body, and that's what she, said, be conscious of, putting chemicals, hair products, and stuff like that, on your body.
Oh yeah, so let me talk real quick about the nail salon, and then you can kind of talk to us about where your mind was after your treatment. Mm-hmm. So a lot of times when you go to the nail salon, they will remove or cut down your cuticle, both at the nail on your fingertips and your nails. Well, that cuticle it's providing a barrier. It's like a fence to all these outside germs that we don't see, and they typically are harmless. But once we have a medication like chemotherapy, which kills everything, right? Because it can't really detect good from bad. So it kills everything, especially those tissues that grow really rapidly. So that's your hair, skin, and nails. Ironically, what we specialize in dermatology. And so that's why the hair goes really quickly. People become anemic, higher risk for infection. White blood cells go down. Those are the ones that help fight infection. Nails, and change it in the skin. Sometimes the skin turns into like more baby-like skin, right? But then it makes it also much more sensitive, and it can get much more irritated quickly. So yeah, so that's the concern. And even if you don't have chemo, we still encourage people when they go to the nail salon not to get their cuticles cut because of that risk of infection. And while you might go 100 times and have no problems, somebody goes 101 times and then they end up getting an infection and they come to see us because it ends up red, swollen, and very painful. Okay, so after treatment's over, where's your mind at this time?
Well, after treatment's over, I get a little graduation. They ring the bell. They give you the certificate. All the nurses, the team come out and say, congratulations. So I was very relieved that that was over with. And I was very happy that the process that, that I had to go through was over. And that the fact that I did everything that they told me to do, and they just loved that. I took my book to treatment. They didn't have to ask me any questions. I already knew that. And and they give you a little bag. And then I started getting counseling with the social worker after treatment, and then that's when they give you all this like $500 worth of Mary Kay makeup. And that's like your key that you can start wearing makeup and stuff like that. So I was just relieved. Yes.
And you participated in something with the wigs?
Yes, they offered free wigs. You could go somewhere and a lady would make up, a wig and stuff like that. But I didn't do that. I just got the information, but I didn't want to, drive out, I think to Manassas or whatever. And like I said, there were so many wigs, online and stuff. And so I just used the option and was just buying, wigs and naming them.
Okay. I didn't know about the naming.
Yeah, the naming Janice, Linda, Helena, I had different names for it. So when I went to work, my supervisor would say, now what's the name of that wig, And, it was really cute. But then after a while, once my hair started coming back, I would wear wraps or hat, because at work, when I started going back to work, of course, the air condition, even when you're outside, I was told to wear your head, you have your head covered so I wouldn't get colds and stuff like that, And so, but yeah, it was really fun wearing the wigs.
And okay, so let's see. After surgery, you didn't really have any changes, no complications with chemo,
No complications.
just the nails, really.
Yes.
And of course, you cut your hair, but you also end up losing like your eyebrows.
Right. And I didn't have that much hair on my body anyway, even underneath my armpits, And so, yeah, I didn't even notice until you said with your eyebrows, So yeah, but still, like I said, none of that defined me. I was just so happy that I no complications and that I made it through the procedures.
And that continues to this day, the kind of eyebrow.
Yes, well, we're going to fix that soon. Yeah.
Okay, and then radiation. And so you told us before you didn't have any complications from that. I have some pictures to share with radiation. So here's a picture of a lady on the bench, and you can see the device is aimed right at her breast tissue. Did you take your shirt off or you kept yours on?
No, I had to take my shirt off.
Okay.
And the radiologist, oncologist, she came in and she marked, the target area, and that's exactly where they put the radiation at. And she prescribed a cream that worked better on African Americans' skin so that I wouldn't have any scarring. And I did that for 33 days straight.
Okay. And so yes, the one complication is pretty common from radiation in that part of the body anyway, is a type of rash or dermatitis, and it can be treated with topicals. Of course, you're advised to stay out of the sun. You were given some of those instructions too, right?
Stay out of the sun, wear sunscreen, wear a hat. Yeah.
Yeah, and some of that also helps with healing so that you don't get like what we call hyperpigmentation, because all that sun to that healing tissue can darken the color of the skin. And so that's to help get you the most optimal outcome or a better looking appearance to the skin. So after you finished that December with radiation, how soon during that time were you seeing your eye doctor or dentist or anybody?
No, I wasn't seeing I was seeing the eye doctor. And I wasn't seeing the dentist.
Okay. Do you remember how soon after that you had your first appointments with them?
Oh, well, once I went back to work, 6 months, 7, 8 months after, then I went and I saw the eye doctor and the dentist.
And you had to update them on your health at that time?
I had to update them on my health, yes.
Okay. How did that go?
That went well. Actually, the dentist contacted the oncologist. Just to follow up with the chemo and the medications, which I wasn't on any medication, but just so they can communicate with one another.
Oh, okay. Very nice. And then you said you went back to work. What was that like?
Oh, I was so happy to go back to work, to be around my friends and get that support. And yes, because I was home in the house for 6 months, and just the family came, and two good clergy sisters came to the house because I didn't want to be around a lot of crowds, because of the chemo. And in the event that someone had a cold or whatever, I would be susceptible to that. So yes, and so back there, everybody was really happy, and we went out to eat some real food, which of course that agency loved to go out, and so very supportive. My supervisor at the time, she's like, if you feel well, you come. If not, don't. I had one of my brothers that was next door, and he had just went through lung cancer.
Mhm.
So he was, like my little brother, he was like making sure you want coffee, whatever. And yeah, it was very good, positive environment.
That's interesting because a lot of times people don't want to go back. They're like concerned about all the questions they're going to get,
Mm-hmm.
especially if they hadn't shared the diagnosis.
Mm-hmm.
They're afraid people are going to start asking questions,
Mm-hmm.
and I don't want anybody in my
Mm-hmm.
business. And
Yeah, and they did, but because I'm a person that likes sharing information, I didn't have a problem.
Okay.
I just did not have a problem with that because I wanted to make sure that they too took care of themselves, and so in order for that to happen, meant that I had to share my story. But it wasn't like, what does it feel like or anything like that. It was just like, how are you doing, and where have you been? We miss you and stuff like that. Yeah.
And how were you? How was your surgical site healing? Were you concerned about your clothing? Were you paying more attention to like the neckline?
No, actually, it's really funny because I didn't even know that there was a change in the level of my breasts
Okay.
until a coworker had said her mother was 76 years old and she was getting ready to go have surgery because she had breast cancer and because she was concerned that they wasn't at the same level.
Mm-hmm.
And I was like, well, what's she talking about? And she said, yeah, she said she had a lumpectomy and she wants everything to be even. So it wasn't until I went home that evening, because I was like, wait, and then I was like, oh my God, they are different, one up and one down, And so, but again, I wasn't trying to have nothing else done. My skin had healed, everything, had blended in, and it's just amazing how God can heal that skin, And so, no, I wasn't concerned because I felt, bra would lift the other one up, and yeah.
Were you afraid to look at that body part? Did you feel self-conscious?
No, because it's my body.
Okay.
It's just like when I had you guys, your body goes through different changes, and so I wasn't scared to look at it. No.
And what about the first time you wore a bathing suit?
The first time I wore a bathing suit, then I was conscious.
Okay.
Because obviously the bathing suit didn't cover that area, But and afterwards, I remember my son. He said that's your scar. He said that's your war scar, and that just means you survived. So that's not something that you need to worry about, So I kind of always carry that, with me.
Oh, good.
And as well as he also said, I'll mention his girlfriend at the time, she loved wigs. So after I finished surgery, the chemo and stuff, he said, well, she'll be with you and y'all can go do some wig shopping because she's addicted to wigs. And she was like, I'm not addicted to wigs. And she was actually there, and we went and bought some wigs and stuff.
Oh, nice.
Yeah.
That's good.
Yeah.
And so you mentioned a little while ago, and I remember like when you first got diagnosed, you started doing a lot of research into like products and water and things like that. You became very aware. So you want to just talk about that and where you are now with it too?
Yes. Well, I was told in my support group, just be concerned about what you put on your body, what you put in your body, and not to watch the spooky websites out there that tell you all the stuff about chemo and what's going to do to your body and stuff like that. So I listened to other women who went through the process, and of course you were always there doing your research on all the natural stuff. And so I just said, well, she's already done the research, I might as well continue like I just still do today with the Tom's deodorant and the toothpaste. And so yes, I think it's good to do research, seek others. Like I said, I had an army of friends who had already went through the process, and so yeah, knowledge is powerful.
That's right. Okay, and so I guess we'll highlight kind of the biggest things. We talk about your nails. How long did that take to go away?
Oh, that was a while. Because by that time I was back at school, and I still had the discoloration, and I wouldn't say 3 months, 4 months.
Oh, okay.
And the toes, I had a problem with the toes, so I had to go through the podiatrist because my toenails had kind of like curled. And he gave me a cream and told me how to file them down. And so one toe, of course, I didn't pay too much attention to. And but now I would say everything's pretty much even down.
And what made you go see the podiatrist? That was your decision?
Because one toenail was like ingrown, so it was like painful when I put my shoe on.
But did you talk to your primary care first, or you just?
I talked to the oncologist.
Oh, okay.
Yeah.
Okay. And then, what about your So then you started. I don't think do you still use plastic? I think you stopped using plastic.
Yes,
and now you carry your own water everywhere.
I stopped using plastic. So I used just glassware, and I changed the cooking utensils, and as well as I just got the aluminum pots and pans, and I still had some glass pots and pans from way back, and thank God I didn't throw them away, so I used that.
Okay, and any changes to your weight?
I lost 25 pounds during that time.
And since then?
And since then, I've gained 25 pounds plus back there. But still, because I walked like 30 minutes or whatever. And they pretty much said that was going to happen.
And so, but now what your weight, we're going to cover the last 11 years, right?
And so,
well, 10 years since the treatment ended. So now what do you do for your health and your weight management?
Okay, so I continued walking. I was doing Zumba at the time, enjoyed that. And I don't think I started the yoga back then. Watching what I eat. And I think 22 years ago, we started you had suggested a personal trainer. And at first I was a resistance because I was so used to telling other people what to do. Then I was like, I don't need somebody telling me what to do. And then when I realized, and the oncologist again, he said, well, that would be very good, for you to take personal training. And also for you to, have someone else telling you what to do. And so I did that. And now I belong to the gym. So I go to water aerobics. I was with personal trainer for 2 years before he resigned. I'm just going to put it like that. But
not because you weren't following the plan.
Right.
That was a personal thing.
Yeah, that was just a personal thing. But I did that Monday through Friday for an hour for 2 years, and that group, dissolved. But I still do personal training now. Like I said, water aerobics. So I lift weights. I'm at 15. I really should be at 20. And like I said, my oncologist felt that everything that I was doing was good. So now, do we talk about some other side effects?
Yeah. And actually, before you jump into that, you talk about your oncologist a lot. So how often did you go back and see them?
I saw him every 6 weeks.
And what was that for?
And that was just, we sat and talked. I told him I don't think he had anything to do. We just sat and talked. I continued to tell him what I was doing. He was happy when we had, I told him that you had suggested that for a weekend or 30 days that we do the vegan lifestyle, which turned out to be 12 years later, even though I have put some seafood in there. So I guess I'm a flexitarian back and forth. But I don't have seafood every day. He was also a vegan, so he thought that was good because of the contamination of that meat, from meat and stuff like that. And so then I saw him every 6 weeks, 4, 6, then a year. And I continued to see him until last month. Because he had put me on the polio, and I had been on that since 2018 for 3 years. And so I graduated from the whole department of oncology in November or April of this year. And, kind of sad because I had knew them, a community, the same nurse for 12 years and stuff like that. And, but they're always there. And so, yeah.
And so you also continued to get chemo. But unlike the Metaport, which was removed, you took a pill now. Remember, you were on Arimidex?
I started on Arimidex, and I stayed on that for 5 years. And the oncologist, my first oncologist at that time, recommended that the studies show that if I stay on for 10 years, the life expectancy was greater. And that was tamoxifen.
Mm-hmm.
And as a result of that, I started experiencing a lot of muscle or joint pain, discomfort, and concerned about my quality of life. Obviously, I called the oncologist and shared that with him. And so we did some blood work and stuff like that, which had detected that I had osteopenia. There was a concern because my primary care had detected, looking through some notes, that my calcium level was over the 10.4 level or whatever. And she was concerned that that would cause osteopenia, which eventually it did. So the two of them got together, back and forth, and the discomfort got even worse. So they said, we don't know, we blood tests, we did everything. You're doing everything that you're supposed to be doing. Let's just do a referral for you to go to the endocrinologist.
Yeah, and I know when you brought it up to me, one thing I didn't, I think at some point we did talk about it, but sometimes an elevated calcium can indicate cancer. And so that was a little bit concerning to me in the beginning. And it took almost a year and a half. They were like, okay, first let's cut down on don't stop taking your calcium vitamin. Mm-hmm. Okay, it's still high. Okay, stop eating yogurt, right? Then it was still high. Mm-hmm. Then they said, oh, look, your vitamin D has calcium too. Stop taking that one, right? And then it was like a year and a half of like, let's stop, let's do blood, come back, it's still high. Let's stop, let's do blood. And it was only going down like a half a decimal. Wasn't really making any big changes. So then they start looking at your medications, and you were coming to that timeline of the Prolia coming to an end with where it's recommended to take it. And you went to talk to your endocrinologist, who I sat in on those calls over the phone, which is an option. If people can't be there in person, I've plenty of times I have talked to family members over the phone, and we appreciate it when you ask and not just do it, like hide it or be sneaky about it. No one's trying to hide anything. It's just nice if you can just fill people in and let them know. And that's another way for people to be an advocate for you, is through the phone. I haven't seen any providers that I have, worked with, not be in agreement to that.
Right, because you was on the phone too with some of the oncologists a couple of times.
Yeah. So with your bones, you stopped the Prolia, but you were concerned. You heard they recommended reclass, right, which is an infusion.
Okay, well, if I could go back a little bit, because we started traveling around that time.
Okay.
And the oncologist, he recommended that I take a vacation off of the Arimidex or the tamoxifen. He said, for 3 months, since you're traveling and stuff like that, let's see, how that does. And so I'm feeling a little better and stuff like that. But then, it reoccurred.
The pain,
yeah, the muscle pain, and which, of course, at that time I was walking, but it was very difficult to keep that pace up, And so that's when together they said, look, let's just send you to the endocrinologist.
And what was her thought?
Well, first I seeked out an African-American endocrinologist in my community. And when she looked at their labs and stuff, she just said, it looks like osteopenia. So then she wanted her own set of blood work. I had to do urine once. I had to do more labs again. Then I had to do urine, and just back and forth and back and forth. And finally, so then there was a thyroid issue. And so she said that we just wanted to make sure that, that there's nothing wrong with your thyroid. And I'm like, well, what is that? Because I'm doing everything I'm supposed to do. What's a thyroid? And she said, it's nothing that you can control, but we just want to make sure nothing's cancerous and the problem, because of the high calcium. So that, to me, to myself, that was an experience, because I had to have a biopsy. And that's when you lay on a table and you cannot move. There's an advocate that's there, patient advocate, the doctor, and a nurse. And she's, of course, trying to take your mind to beautiful beaches and everywhere. And I'm thinking, no. So he explains you have like 4
Parathyroid.
parathyroid, and they had to stick several needles in each one. And I couldn't move. He said, because if you move, then we have to start all over. I did not move because we was not starting all over. And again, they were thin needles. And he said, you're going to feel a little pressure. See, I don't mind if they say you're going to feel a little pressure, but if they like, just stick it, then that's why I'm like, And so he said, you're going to feel a little pressure. And yes, ma'am, it was pressure. And each one several times. And I think that process was like 45 minutes. And I went by myself. Yeah, I went by myself. I believe I went by myself. Yeah. And because I didn't know, because when I had the breast cancer, it was just, I was with someone, but it was just one spot in and out. So I'm like, oh, biopsy, And I didn't educate myself because I didn't really want to know. So I just went, and so they said, you didn't need anybody to drive. So I'm like, okay, so easy in and out. Well, it wasn't. It was a challenge. So anyway, that came back, and I think 2 or 3 days, she called, the endocrinologist called and said that, according to their team, that it was just in my DNA that I had this calcium, high level calcium, and that she would recommend, which she recommended the first time I saw her, you need to get on reclass. And I was like, I'm not getting on that. I don't need to be on another toxic medication, because I did my research. And she said, well, you can't just not be on anything for osteopenia, because then it's going to turn into osteoporosis. And because you're so active, you don't want to, you don't want to have any fractures and fall and stuff like that. And, and so I kind of waited a while. And then when my knees and stuff started hurting, and because I have a history of arthritis, my mother and the family, that's why it's important to know your family history. So that was, my history was arthritis as well. Because of my mother, I seemed like I had almost everything that she had. And so I just called the one day after I talked to you and researched some people, with some people who had actually been on it. And they said, girl, you've been through chemo. That is nothing compared to the chemo. And so I called her, and we scheduled the appointment. And I had to go take more blood work, no more urine, and it was still like 10.4. So it was still high. And so I just went and I had my first reclass in an infusion room.
This last week.
This last week. Yeah. And you said, oh, I'm so glad you finally decided to do that, And so,
because you had done your research, you had extensive conversations with your provider who you trusted. She answered your questions. She respected that you wanted to have your family involved. You waited a long time. You were going through a lot of pain, taking Tylenol and applying pain ointment, icing, massaging, pool, yoga. Like you tried everything, right? What we call conservative treatment, right? And so,
Yeah, and so I just decided, just go ahead. Again, concerned about my quality of life, and want to stay as independent as I could and still enjoy the things that I was doing. So I just said, again, I had to put my faith, in God, and know that as He got me through the chemo and radiation without any complications, that He and we'll talk about this on the Faith podcast, but that everything would be okay. And talking to one of my pool pals who was a 25-year breast cancer survivor, and she's still here. And so I just went on to have it. And how do I feel? I feel great. Having used the ointment on my knees.
Diclofenac, which is a pain. It's kind of like I like to describe it like a topical ibuprofen, Aleve. It helps with inflammation, but like we said, it's topical.
Yeah.
Okay, yeah. So, but at first, the first night, I think you felt Great. Then the next 24 hours, you were like, oh, they
Right.
told me.
Yeah, they said 4 days, and within, you might feel a little pain, discomfort, and within the next 4 days. But that's fine. Just take Tylenol. And up until this point, Tylenol has been my friend. And
We love Tylenol in
yeah,
healthcare.
yes,
Yeah,
and
we
I
do.
love it too. And
As long as it's within the recommended 24-hour dose.
Right,
Because you
right.
can develop liver
And
problems,
I was just
among
thinking
other things.
maybe like 2 or 3, maybe 2 in the morning, 1, if I was working out. So, yes, and the day after or 2 days after, that's when I felt, my knees and the lower part of my thighs was hurting, And so I said, oh, I think this is, I think this is working. Something's going on here, And so, yeah. Mm-hmm.
Yeah, and I think with the knee pain in particular, it kind of slowed you down a lot. You were very active, and then you started having the rocking, like the back and forth, kind of the rocking, and then it was getting into the hips, and you couldn't really stand for long periods of time.
And I called the primary care.
Yeah.
And she said, well, it sounds like arthritis in your knees. So that's when she prescribed the ointment.
Yeah.
Yeah.
I just noticed since the Prolia stopped at the beginning of the year, each month that goes by, it was kind of like the pain was just getting worse and worse. And yeah. So I'm very excited to see the results on this. And
yeah, I am too.
Yeah. And so since we're talking about we're going to close this out and then I'll open up a new one. But with your bones, you also had, maybe we'll do it in the next one. Talk about your bone scans.
That'd be nice.
Yeah. Okay. So we're just going to pause here, to be continued, and then we'll come back and talk about her other health changes and what she's doing to make her relationship with her other doctors and what the future looks like. Okay, everyone? We'll be right back.